Okay, thank you very much, Andrew. You're all very welcome to the ISAG public webinar this afternoon on women's perspectives on the global 19 pandemic. We're delighted to have a range of speakers here with us today, speaking from different perspectives on the impact that COVID-19 has had on women across the island of Ireland and across from a range of experiences and expertise as well. My name is Nessa Cronin. I'm Associate Director of the Moore Institute at NUI Galway and a lecturer in Irish Studies, and I'm a member of ISAG, and I'm delighted to be chairing the session here with all of our attendees and our panellists here today. Since March 2020, the question of women's experiences, voices and perspectives has been of growing concern to many in Ireland and Europe and internationally indeed. Discussions about the question of work-life balance or imbalance came about with the first lockdown, and then we very quickly saw how the politics of care and the economics of care came to the fore, or was indeed, one could argue, ignored very quickly after that as well. Attendant to that were other issues about the invisibility of life behind the front door. We got lots of glimpses of empty streets around the world, and around Dublin and Cork and Limerick and Galway and Belfast. Different cities in Ireland were now emptied of people, but the lives that were behind the front door were lives that were often unseen, were invisible, and very often unheard as well. And as it happened, very often the burden of the care and responsibility for those lives behind the front door often bore down on women in Ireland in particular. So this in more recent times has led to growing calls to address issues of gender-based violence, caring responsibilities, the domestic division of labour, child and elder care responsibilities across Ireland and Europe more widely. Women who still have paid employment, and many women do work in the home but are unpaid for that employment, have seen their careers tanking, and there's been lots of research on the impact, the negative impact of COVID-19 on women who have paid employment outside of the home. But there is also an immense toll that is felt in terms of their physical and their mental well-being, both inside and outside of the front door as well. In January 2021, MEP Frances Fitzgerald brought forward a report on gender and COVID-19, which was adopted by the European Parliament. And it was a report that argued that the national action plans for EU recovery funds should and must be gender-proofed. Our webinar today is continuing that call, but however, it's arguing that not just that the recovery has to be gender-proofed, but the response today has to be gender-proofed. And the idea of response today and recovery in the future, one thing necessarily leads on to the other. We cannot have a recovery without an appropriate response today. So with that in mind, ISAG has always argued that an all of society problem demands an all of society approach. And we've always been arguing as well that we need all island perspectives to critically understand and to best shape the best kind of outcomes for the people living across this island today. So I'm delighted to welcome our speakers, but first, before we move into the discussion part of the webinar, I'd like to invite Professor Patricia Carney, Professor of Epidemiology from UCC, to give our weekly ISAG update report. So Tricia, over to you. And you can unmute. Yeah, great.
Yeah, great. Thanks, Nessa. So delighted to have the opportunity to give you a very brief situation update, and the data here was prepared by my colleague in ISAG, Paul Dempsey. I'm a professor of epidemiology in the School of Public Health in UCC and a member of ISAG. So I suppose the story to a certain extent, or the situation update, is that things are continuing as they have been. And if we look here at the most, this is a graph that you would have seen for those of you who are joining our webinars every week. You'd have seen this before. And so what you see here is the average number of cases per 100,000, and the different lines there. On the y-axis and on the x-axis, what you see is the date. And I suppose in terms of looking at where we are now, some important things to point out. The good news is that we can see that spike that we had seen, in particular with the healthcare workers, we can see that is coming down now. And so that is definitely a positive trend. And if you look really across, we see all the the different age groups are pretty much parallel to each other. The one, I'm not sure if you can see that, but in the younger age groups, in the very most recent period of time, you may see a little bit of an uptick. So it's not a cause for alarm, as you'll be aware. And this is one of the things that you know, you always need to be aware of when you're looking at data like this, is what's going on behind the data. And so we all know that because of what happened over Christmas and subsequently, that we had different criteria around testing, and we stopped our close contact testing, for example. And so that has restarted again, and perhaps not unexpectedly, that has had the most impact in terms of those younger people who we know are more likely to be palsy or asymptomatic, and so may not have come forward when we were only testing symptomatic people. And so really, I suppose the overall message here is that we're continuing to see the same trends that we've been seeing in recent weeks. So a good news message. A little bit more of concern, I suppose, is when we look at the underlying variants, and there's been a lot, I know, of coverage of the different variants. This is based on the data that we have available to us, and what we see here. So the black dots are the B.1.1.7, the new variant that we've heard about and that we know is associated with greater transmission. And what we see here, so the black dots are real measures, and then we also do modelling. Again, we're looking at this over time, and I suppose the cause for concern here is that clearly the huge efforts that everyone is making, you know, staying at home, adhering to the public health guidelines, we see that the case numbers are dropping, but we're not seeing the same level of impact on the more recent variant. So that's it from me. Thank you. Hand back to Nessa.
Great, thanks a million, Tricia, that's great. And thanks to Paul and everybody as well for collating the data on that for us as well. So we'll move into our panelists now. I'll introduce them collectively, and we'll move along in order, and then we will also be happy to take any questions and answers from attendees as well. So please feel free to use the Q&A button at the end of your Zoom screen there, and hopefully we'll get to most of the questions throughout the session as well. So Gabrielle Colleran is a consultant pediatric radiologist, and she's also the Assistant Clinical Professor of Children's and Women and Children's Health at University College Dublin. Then we also will have Cliona Ni Cheallaigh, who's Associate Professor Consultant in Clinical Medicine at St James's Hospital and Trinity College Dublin. Then we will have Sharon Lambert, who's Lecturer in Applied Psychology from University College Cork. And then we will have after Sharon Kelly Talland, who's a rare lung diseases advocate, and she will be talking about life with a rare disease during a pandemic. And then finally, last but not least, we're delighted to have Shauneen Brown, who will be discussing about questions and answers on living with cancer during a pandemic as well. Okay, so Gabrielle, I'll invite you to speak for a few moments. If you can put your mic on, please, that would be great. Thank you.
So I just have a few short minutes, so it's impossible to cover everything, but to briefly summarize a few of the critical points. One of the criticisms of the Public Health Service in the past has been a presumption that it couldn't be agile or innovative in a short space of time. And what we've seen in the last 11 months has really knocked that on its head. And that's a credit to the frontline health workers who have led this change and who have delivered this change. And it also shows that when you empower the frontline and you give the frontline the resources to effect change, that can be performed quickly and effectively. What's really concerning for me as a consultant who's also representative of consultants is the level of burnout and exhaustion that we're seeing now. So going into this, worldwide, 1 in 3 doctors, meet the criteria for burnout. But in Ireland in 2018, so well pre the pandemic, we were at 45%. And so the impact of the pandemic in the last 10 months, people getting sick, colleagues getting sick, cross-covering, having the fact, that we have the lowest specialist numbers in Europe meant that the consultants that we have carry an excessive load. So the pandemic has just exacerbated that. The National Doctors Training Programme estimates that we need to increase our numbers by 51% by 2028. And we also have, 20% of our posts not filled on a permanent basis, 720 empty posts. And so a real concern that we have now is that this cycle of rolling lockdowns will continue with huge pressure on consultants and on all healthcare staff, but that actually as we come out of the pandemic, that we will see an exodus of staff, that people will either leave to emigrate to better systems, or they will just leave to switch careers altogether at exactly the time that we really need more people. And a significant concern for us is that the urgency that we've seen with regards to the pandemic has to be replicated for tackling the waiting list. There are over 840,000 Irish people waiting for care. And there's an urgent need for that to be tackled with the same effectiveness that we have and the same urgency that we've seen for COVID. Our hospitals aren't fit for modern infection control. We have a real lack of single rooms. We need modern hospitals for modern infection control. And that has to be tackled if we are to retain staff and if we are to provide 21st century healthcare. So when I'm talking to staff, our critical concern is that that urgency will not be there and that staff will actually be blamed for high levels of nosocomial infection, when in fact we don't have the infrastructure that's fit for purpose and we don't have enough staff. And when staff are exhausted and doing extra shifts, of course that impacts on infection control, it impacts on the quality of care. The schools closure and the fact that there wasn't a plan for us, that unlike colleagues in Northern Ireland and the UK, that there wasn't a backup for us and that staff were just told to improvise and make do. So we're in a setting where we come home late at night and we're meant to somehow homeschool our children who are also more anxious and are falling behind and don't have parents working from home to be able to support them, has really damaged morale within the health service. We really feel quite abandoned by the state at exactly the time when we ourselves, until we were vaccinated, went to work every day knowing that we were at risk of getting sick ourselves, getting long COVID. And so the fact that there was no plan for us has really impacted negatively on morale, and we have strong concerns for recruitment and retention. So those are really the points that I wanted to bring today, and I'm keen to get to the panel discussion because I feel that's probably where this will be most rewarding for people. Thank you.
Okay, thanks a million, Gabrielle. Some very salient points there, and I think we could spend the whole webinar, I think, talking about all of the individual points you brought up. But again, I think these are things we will be discussing throughout. I'll move now to Professor Cliona Ni Cheallaigh, who's going to speak on the effect of the pandemic on marginalised groups. So Cliona, over to you.
Thanks a million. It's lovely to be asked to talk today. I'm really looking forward to the discussion and hearing everybody else. So what I wanted to bring up, I suppose, was about the disproportionate effect of COVID-19 on people who are poor. So we know that they're twice as likely to die from COVID as people who are richer, and that's to do with multiple factors. But basically being poor is really bad for your health. And the people that I work with in James's and that I'm really interested in looking at health services for are people who, Michael Marmot, who's a big specialist on health equality and social determinants of health, he calls it poverty on stilts. So it's like experiencing poverty, but with the volume ramped right up to maximum volume. And in our society in Ireland, they would be people who are homeless, people who inject drugs, people from the travelling Mincar community, people who really haven't been served very well by our state and who tend, unfortunately, to be the victims of bad policies and bad planning. And unsurprisingly, COVID also is affecting them worse. So we have some initial data from James's. I might just try and share my slide if I can. Just showing this is looking at predictors of severe disease, but you can see that even more than age or clinical frailty or being male or being a smoker, things that we know are associated with getting very ill with COVID and dying from COVID, that homelessness was the biggest risk factor for severe disease. And we're seeing that throughout this pandemic. I think we've 3 or 4 homeless people on our COVID wards at the moment. So I think it's just so important, and when we're thinking about living with COVID, you know, how does that look to people for whom their lives are already very difficult? How does that look for people who already don't have access to housing and are living in dormitory style accommodation? How does that look for travellers who are in overcrowded accommodation? And how does that look for communities where the trust isn't there between them and the health system and them and the state? So we really need to factor that into all our decisions, both our decisions around what is worth investing in, and then all the practical decisions around how things are going to be implemented, because otherwise what will happen is what always happens. There's an actual law of inverse proportionality, which is the more you need a health service, the less likely you are to be able to get it, and that will be true for COVID as well. That's it.
Okay, thank you very much, Cliona, and thank you again for making the time to be with us today. And while we had framed this as, you know, a webinar about women's issues, you know, it is as much about women's issues as human rights issues. And I think those issues you brought up as well about social justice are key arguments that many people have shown and are arguing that we need to be more attentive into how COVID has shown structural inequalities there.
Absolutely, and I think one of the, from a feminist point of view or from a women's point of view, social exclusion affects women even worse than men. So we know that usually women have longer life expectancies than men. That's flipped within the homeless community, for example. So 44 years for men is the average age of death, and it's 38 for women. And for women who are socially excluded, for whose children are in state care, for example, they haven't been able to see them because of COVID restrictions for a long period of time. So we really treat excluded women very badly, and COVID has made it worse.
Yeah. Thank you very much, Cliona. These are all salient points that I think we'll have to be addressing, not just here, but further on and further afield as well. Thank you so much for that. We will be moving now to Dr. Sharon Lambert, who's a lecturer in applied psychology in UCC, and Sharon's going to talk to us about impact narratives from women on the front line. So Sharon, over to you down in Cork.
Thanks very much, Nessa, and I hope you can hear me okay, because I was at 11:30. I was sitting in a dentist chair, so I was still a bit frozen on one side. COVID Women's Voices is a very large group of women, and I suppose some of the things that we were looking at was the very high proportion of women that are operating in roles that are essential to the operation of the state. So education, health, and other caring roles.
Okay, I think Sharon, your line is just a little bit wobbly there. Are you back with us?
I am, but if you can't hear me, do you want to just move on to Kelly if you can't hear me?
I can hear you okay. Yeah, you're good now.
Okay, that's the joys of rural and being no broadband. So so COVID Women's Voices, we were conscious of the fact that a large amount of the jobs that are carried out that are essential for the operation of day-to-day living are predominantly occupied by women. So teaching, healthcare workers and other caring roles. 76% approximately of healthcare workers are women. And you mentioned at the start, Nessa, about the impact on women. So we know that there were studies done by the World Economic Forum, the London School of Economics, the New York Times wrote quite a good article about the gender disparity that has emerged in the last year. So while there were always issues in relation to gender equality, it has taken a big setback in the last 12 months. So in terms of some of the narratives that we've collected, things that people mightn't have thought about are, you know, the children of healthcare workers are experiencing a significant amount of anxiety because they're concerned that a parent is going to get COVID and that they'll die. So there's an increased number of children of healthcare workers who are presenting with anxiety now. A lot of the women who work in these roles reported to us that they have huge amount of guilt about those who are on waiting lists and waiting to access the services that have been impacted because of redeployment due to COVID. You have, 76% of healthcare workers are women, so they're disproportionately impacted by the amount of COVID that they have gotten, and also disproportionately impacted by the fact that they have many more women now have long COVID within those roles. And Cliona has already spoken about minority groups. 1/3 of women in the travelling community in Ireland do not have access to running water, which we know is incredibly important at the moment. And the other thing that has come up a lot actually is the impact of the level of death that healthcare workers are dealing with. So we know if you look at previous pandemics like SARS, that the impact, the psychological impact of that was felt for 12 to 18 months after everything had settled down, where you still had very high levels of anxiety, depression, and post-traumatic stress disorder. So I suppose the COVID Women's Voices, looking at all of this, have very clearly said that they cannot face into a fourth wave of this. It's unsustainable what is going on, the burden of care that's falling on women in these roles, coupled with the burden of care that they have outside of their working professional lives, they're more likely to be taking on more responsibilities in relation to caring for children and elderly relatives.
Okay, thanks a million, Sharon. And I think even the difficulties with broadband and Wi-Fi shows different kinds of inequalities as well, geographical across the country, that many of us struggle with as well. And children in terms of accessing homeschooling, whether they have a laptop or don't have a laptop, they might have to sit into a car and go to a car park somewhere to access Wi-Fi as well. And I think all of those different issues as well. I think there has been reports in terms of the population in Bergamo and the impact of the trauma from the first wave on that as well. And I think there's lessons there, unfortunately, that we will be learning and experiencing from as well in Ireland post 2021 in many, many ways. We'll move on to our next speaker, and we're delighted to have Kelly Talland with us. Kelly is a rare lung diseases advocate, and she's going to speak today from her own experience on life with a rare disease during a pandemic. So Kelly, over to you.
I hope you can hear me properly. The connection isn't great up here as well. Yeah, so I've got 3 rare lung diseases, which makes it an ultra rare disease. So what I found that was back when this pandemic started, I didn't even know if I was a high risk, because the HSE never actually listed my disease as high risk because it's so rare. So what my GP and my respiratory team just told me to cocoon on the basis that it is a respiratory illness. So what I found back then was that I've got no support, so I've got no big advocacy groups, there's nobody shouting on my behalf. So even when we come to stuff like vaccines, and you're like, how are you going to be identified for a vaccine? But not only that, I was admitted to hospital 4 times last year. My team now run a fully functioning day ward, but because I've got a rare disease, I couldn't access that day ward. So every time it would be through COVID A&E. And I wouldn't be under my own team, so it'd be under a team that haven't got a clue, don't know anything about my disease. So it'd be only my respiratory team that would know. So at one point last year, I felt like, are we really all in it together? Or are we only advocating for some? Are we only advocating for more common diseases? Like, are the ones that rare diseases just forgotten about? And I also have an 8-year-old son who's waiting for an assessment of needs 3 years too late. So I had to send him back to school last year. Like, he needs his education, but the only reason for him to get an assessment would be to go back to school, because the assessments are carried out in school, and he's still waiting. So he's not back in school. So I don't know when he's going to get his assessment, because none of that is running. So I think we need zero COVID on the basis that our kids are let down, and then there's people with rare diseases that are just completely let down too.
Absolutely, Kelly, and I think as well, this ties into a webinar we had recently on education as well, and the questions of hybrid learning came up in that, in terms of, can children learn from home or else going into the school on a different rota basis, but the risks that are there for children and for siblings and for parents that have vulnerable health conditions or rare diseases as well is something that hasn't really been appropriately dealt with to date. And so it's we're all the more grateful for you for being here with us today to give us an insight into that. And we will move finally to Shauneen for our last presentation this morning. And Shauneen Brown will discuss her own experiences and her thoughts on living with cancer during a pandemic. So Shauneen, over to you.
Hello, thanks for having me. Can you hear me okay?
Absolutely,
yes,
loud and clear.
Yeah, well, I was re-diagnosed, or had a reoccurrence of my esophageal cancer back at the beginning of the year, and unfortunately started my chemo and radiotherapy just sort of the week that the first lockdown was announced. So as you can imagine, you're dealing with all that issue, and then the next thing, you don't know what's happening with this new disease or condition that was happening. So I was having to go to the hospital every day for my treatment just when that was happening. Thankfully, my treatment went ahead, and I was brought in and told that it could stop at any minute or any day, dependent on how things were going. I mean, that was an awful amount of stress on top of what was already happening. But thankfully, I was able to go ahead and get the 5 weeks of radiotherapy and my 3 rounds of chemo. But it was a very stressful time, and I would generally not be someone who stresses out too much, but with COVID, I mean, I was terrified every day attending the hospital. Was I going to get this? You know, how was it going to affect me? Thankfully, I was treated in Belfast at the cancer centre, and I have to say, I was lucky enough that everything went ahead and I was treated very well. And I know of other people who had their treatments cancelled and operations cancelled, and I'm just lucky that thankfully that didn't happen to me. But it was always in the background there that could be a possibility. So you know, living with cancer at the best of times is hard, but in a COVID situation, it was just terrifying. I mean, I was having panic attacks every day, and I wouldn't be someone prone to that. But it's just the unknown, I think, and because it was so new and no one knew what was happening. Every day I went up, you know, the first day people weren't wearing masks, and the next thing you had to wear a mask. Then obviously my husband couldn't come in with me, so he had to go in. It was a very lonely experience for me. But I mean, I'm thankful I'm here. I got through it, and I'm on the other side now. But I know that people are still struggling daily. I heard today that the operations for my specific cancer, the sophocectomies, are just started again, but they've been cancelled for months and months now. I mean, my particular cancer is a very low survival rate if it's not caught early or treated early. So I can only imagine if I was diagnosed now in this position and not offered the operation because of COVID, you know, we're going to have a lot of people who just aren't going to make it through it because they're not getting the treatment due to COVID. And I don't know how that's dealt with. You know, people aren't going to their GPs for referrals. Referrals are down, you know, 25% at the minute. They were more at the beginning. Thankfully, people seem to be going back to their GPs, but I don't know where that leaves us long term. I think we're facing an epidemic of issues after COVID goes away, or you know, if it ever goes away, but of people who just haven't. And it's not just cancer, it's every other condition and illness. And I don't know how that's going to be dealt with by the government or by healthcare, because we barely have the ability to deal with the issues we have now. How is that going to work with you know, thousands of people after this presenting with late symptoms? Therefore, you know, I just don't know how that's going to work. It's not good.
Absolutely. Thanks so much, Shauneen, and great to see you looking so well and being able to hear
Thank
you so clearly as well.
Yes.
So it's fantastic.
Yes, we are glad that we have a good connection here. We're very fast broadband, thankfully.
Oh, well, it's great. It's great to have you with us. But I think you've brought up a really important point about the issue of the impact, the other side effect in terms of other kinds of epidemics, and I think Gabrielle had already mentioned as well the impact in terms of waiting lists as well, both in many parts of the country is something that we will be dealing with, unfortunately, for many months and years possibly to come. We've had just a few comments there about just looking at like discussions about this idea of uncertainty, and that, you know, we've been arguing that, yes, we've been thrown into this pandemic and this crisis since March 2020, and it has been an extraordinary period of uncertainty. But that's all the more reason why we have to have a plan, and why we have to have strategies, and why we need to coordinated thinking, and why we need an all of society approach to these problems and these issues, and to listen to the voices and experiences of people, so that there are no critical blind spots left, and that there aren't any structural deficits or inequalities that haven't been addressed going into the future. I'd like to maybe perhaps invite Frances Fitzgerald, perhaps, if she'd like to say a few words. I made reference to Frances's report on gender and COVID, and on the need, her argument for any recovery plan and recovery funds in Europe to be gender proofed, And I think this webinar is showing that we need the response now also to be gender proofed as well. So Frances, would you like to say a few words about your own work and your thoughts on what our wonderful speakers have said this morning?
Well, it's thanks very much, Nessa. You can hear and see me okay? Yes.
Absolutely.
Great. Always worth checking. Look, I mean, it's pretty devastating, really, isn't it, to hear from our speakers today about, you know, the actual enormous impact of COVID, and just sort of reinforces the case for controlling COVID in every way possible as quickly as we can, so that we can begin to deal with some of these personal issues that have come up, health issues and so on. Just to say, Nessa, I did a report for the Parliament, and it went through the Parliament plenary session 2 weeks ago, and it was a report on the gender perspective of the COVID-19 crisis and the post-crisis period. And really, I think the case has been made already by the speakers this morning about that, you know, to be aware of this differential impact. I mean, there's the differential impact is, of course, seen in gender. And we haven't heard enough about it, actually, but we absolutely need to get it into policies and practices and, you know, general public awareness as we go on, because if we ignore it, we're ignoring the actual experience, the differential experience of women and men. Of course, COVID impacts everyone, and, you know, the whole community is affected, but we really do need to look at the differential impacts. And that's what I did in relation to gender in the report. And I looked at a number of areas, and I'll just very briefly say to you, I looked at health, and we've heard about that already. And then there's also the issue of, say, sexual and human reproductive rights and access to services. I mean, they've been really difficult for people, and you can only imagine the personal traumas that people have faced. Then there's the issue of the increase in violence, which is right across Europe. And many countries are adopting sort of innovative ways of women, and indeed some men, being able to get help if they're confined to home and they're in that position. And it really highlights the need for services to be continuing in the same way as we need health services. The economic impact as well, because women's work is proving to be far more vulnerable than men because of the precarious employment. Again, affects everybody, but differential impacts. And the point is, of course, if we're not aware of this, in terms of the recovery, you're not going to get the program. So, for example, there's $1.5 billion coming into Ireland from the recovery funds. Now, we're a contributor, but we still will have an extra $1.5 billion from the recovery fund. We'll also have a national government plan that I think everybody in this webinar needs to be aware of, that has to be put in by April. So we want to make sure that the issues, for example, around care, because there's enormous care issues emerging from the pandemic. You know, who does the caring? How are they supported? And, you know, are they considered frontline? And so on. You know, the health and medical people here know more about this than anybody. And then, of course, you know, if you look at it internationally, we're having more FGM, we're having more forced marriages, and all of these issues are going to have to be addressed as we come out of the pandemic. So the report is looking at all of this, it's describing it. We have very good statistics now. You know, I mean, it is kind of extraordinary to think across Europe that the figures that I've had verified by IGA are 76% of healthcare workers. Now, that's the broad range of healthcare workers, including residential care homes, or women. 82% of cashiers. Like, you don't think about when you go to the supermarket, who's the person face to face with everybody? 82% of them happen to be women. 93% of childcare workers and teachers, 95% of domestic cleaners and helpers, and 86% of personal care workers. So, you know, you don't have to spell out the impact of that. And I suppose the very big area then of childcare, and that's been touched on already. And, you know, working from home isn't a substitute for childcare. And yet people have been left with, you know, without childcare, both those working at home and those on the outside. And it's interesting how it wasn't considered, you know, absolutely central in our recovery, and that it's been so complex to get a handle on, and yet it's so central. So, you know, you've already spoken about vulnerable groups. I've looked at vulnerable groups as well, the differential impact and what we need to do in relation to that. And again, you look at people like, you know, female entrepreneurs, which, you know, that's where a lot of jobs could be created in the future. We're going to have to be alert to all of these, you know, very broad issues. And obviously there is that, although obviously it's changing with younger men, I mean, there is the trying to combine even more work. And it is interesting that we're hearing that from a research point of view, less papers have been put forward by women. during the last few months than previously. And, you know, what's that about? What pressures are women feeling, and therefore not getting to their research? It may be true of men as well, but it's stronger with women. And finally, the voices that we hear, women in decision making, just to be so alert to that, that we do hear the female experts as well as the male experts is very important, I think. So just to refer you, I put up a link to the report for anybody who's interested in the detail. But it's really saying, you know, member states across Europe, you know, have to get a handle on this and realize their different impacts, and therefore the solutions that, you know, as we go past the crisis are going to need to take account of this.
Thank you very much, Frances. And I think actually a link to that report would be very helpful, and we can also add it to our ISAG website as well for further information, and we can tweet it out afterwards as well. Thank you.
Thank you.
I think one of the things that's been most depressing, though, as a woman watching the news screens every night, and I'll invite all our panelists now to come in at this point for just more general discussion, is that the decision makers and those that are on the screens tend to be male. And in terms of the political leadership in the country, the three main party leaders are male. Most of the individuals we see on the screens associated with NEFIT tend to be male, and the head of the vaccine rollout strategy group is also male as well. So the question, I suppose, that I've heard amongst my friends and colleagues and family members who work in healthcare in particular, is that they don't want to have a clap at 7 or 8 o'clock at night to say well done. They don't want to hear words or thank you notes. In a way, they actually want action, and they want assistance in terms of properly resourcing them to do their work and to keep patients safe and well, so that patients like Shauneen and Kelly and their children and their families can be appropriately well looked after with wraparound social care that is needed in these times. So in terms of that kind of disparity between words and action, is there anybody from the speaking panel that might like to address that? You don't all have to jump in at once. Gabrielle, I see you smiling there.
Yeah, well, I guess one of the frustrations that I have is that 79% of our healthcare workforce are female. But when we turn on the television at night, we're consistently hearing from men at all levels. So women are carrying a disproportional burden in terms of actually doing the work, but then are not being represented at the decision-making table to the level that we should. We're 51% of the population. And that is reflected in how issues that have differentially affected women are handled. I'm also frustrated in the level of female representation on TV shows and on radio shows. And again, you know, it's male voices that are centered. And the reality is, and this is uncomfortable for the men who are benefiting from this privilege, and some of them are men on this panel, is that some of those men need to start turning down those opportunities and saying, no, actually, you need to have Cliona Ni Cheallaigh on. No, actually, you need to have Sharon Lambert on. No, you need to have Rosemary Mohan on, because actually, you know, the traveling community are having such a horrendous experience during COVID, where systemic inequality is, you know, really being brought to the fore, and we need to hear from their representatives on how we can do better, led by them, not us, you know, imagining what it's like to be a traveler. And so, you know, male advocates, male feminists, you know, have a really important role in actually saying, do you know what, you've heard enough from me. It's time to hear from women. It's time to hear from Black people. It's time to hear from travelers. It's time to hear from people like Kelly Talland that have rare diseases who are being disproportionately impacted. Their voices need to be centered. We have, you know, heard enough, you know, distinguished, you know, male privileged voices, and that's uncomfortable, and I appreciate that, and you know, but that is the reality if things are going to change and if our response is going to improve. It's no coincidence that, you know, the schools were closed and that there was nothing in place for healthcare workers who are mainly female. The reality is that it didn't impact as much the decision makers at the table, and those of us who are struggling trying to juggle homeschooling, you know, putting together, patch together childcare while providing frontline care. It's hard for the people most affected to actually take the time out to advocate for improvements, because they're just so busy, like ducks paddling frantically under the water, trying to keep the show on the road. And it is extremely frustrating to turn on the TV, turn on the radio, and not hear yourself represented.
Absolutely, and I think in many ways that we all need to be allies for other kinds of groups as well, not just the group in which we're all, you know, personally situated in as well. Is there anybody else from the panel that would like to come in on that, or any other point?
Nessa, could I just make a slightly a different point, and this is just from my own experience. I do want to say, Gabrielle has obviously made a very clear point there about the male voices, but can I make one point? It's been so important to hear scientific voices and research voices coming through. And a lot of them have been men, I do accept that. But, you know, for me as a politician who's, you know, who sees populism in so many arenas, you know, and you can still have, you know, populist approaches undoubtedly, but I do want to, you know, sort of praise the scientific community. Of course, I want to see balances of men and women, but it has been, for me, it's been great to see, you know, going back to expertise. And I think that's really important as well. Just to, you know, to make that point, as it's not a counterpoint, but just to say.
We have amazing scientists and many of them are women, and we have
Yes.
amazing public health specialists and most of them are women, and we are not hearing enough from those women, and it's hugely frustrating. You know, I see Sarah Carey, a journalist today, peddling misinformation about travel, even though Marie Casey, a public health specialist, has corrected her multiple times about the misinformation that she's putting out on this topic. It's incredibly frustrating not to see those public health specialists who are leading our regional response not centered in this, because they are the most qualified people to give opinions on it. I would applaud you, you know, MEP Fitzgerald, because, you know, you have come through politics in a time when it was extremely difficult to be a woman in politics. And, you know, for those of us who are women watching, it's an extremely toxic environment in which you live and practice, where you're held to a differential standard to your male colleagues.
Well, thank you, Gabrielle, but I do want to make the point, it wasn't to contradict what you had to say in any way. And to take up the point, it would be good to hear more regional public health specialists on our media as well, because COVID affects all parts of the island, and it would be great to be hearing those voices.
And I think those voices would like to speak, but maybe aren't, within the structures that they're working with, aren't given the freedom to speak. And I think that would really significantly contribute to our fight against COVID, to have those voices there. So maybe that's something we could feed back.
If I may, I think we should actually call that there is a serious effort to shut up the public health consultants. A very serious effort, and it is wholly unacceptable, because they are right and the people telling them to be quiet are wrong, and we are paying the price in dead people, bunged up hospitals, sick people, and long COVID for them being told to be quiet.
Just to jump in there on what Anthony has said, when I was collecting the impact stories, a large number of women told me that they were not able to speak publicly because they have been told by their management that they are not to discuss challenges within their workplace in a public forum. That's completely, I mean, I'm an academic, we have academic freedom. We actually have a responsibility when we collect data from people to report that data so that it has an impact. And there are people who are working in lots of jobs around Ireland who are being told that by their management that they are not to discuss the challenges they have at work publicly, because we're going to pretend that everything's okay. And just in relation to the scientific community, there was a study done in the UK last week where they analysed the number of times that female scientists were mentioned in the media in comparison to male counterparts. And I think it was 70% males were mentioned in comparison to 30% females, even though there would be much more of a gender balance in many of the roles. And as Anthony said, most of the public health specialists are actually female.
I mean, this is a wider societal issue. I mean, we're just seeing it now at the finer point of COVID, unfortunately, but there was a report as well out in terms of music in Ireland that 85% of Irish music played is with male musicians and male voices on the radio. So, you know, what are we telling our younger children that some of those that are listening to radio now, I don't know if any of them listen to the radio anymore, but that those gender-based issues are right across Irish society in many ways. I think Sam McConkey wanted to come in, and then maybe Gabrielle Scally, if that's okay.
Maybe I don't want this to sound like a defense, but I'll just add, this has been obvious right from the very beginning. And I pulled through my old emails. So on the 20th of March last year, I emailed the 3 or 4 producers and leaders in RTE that I know, and said exactly this to them, that there's been, myself, Jack Lambert and Paddy Mallon have been largely talking about this. And I named out 14 eminent qualified women in infectious disease and public health that they could contact as an alternative. And I think they tried to do that. Then they came back to me about 2 weeks later, apologetically saying, you know, we can't get people to do the sort of 6:30 in the morning news blast or the 11:30 at night, and people are saying no. And that is a huge problem. Once you say no 2 or 3 times, then people don't call you anymore. And this is an issue that people have other responsibilities, as we've been discussing. So I think it's the sort of way our society is structured. Unless you can do the consistent 7 a.m. and 11 p.m., it's difficult to be in that space. And that's, I'm sure, the same in politics and many other areas. But I agree this is a problem. Then when I went on holidays in August, I went around all my friends who were women and said, can I give your number out to anyone, to the media as an alternative? Because I didn't want to do anything in August. And I really, really struggled. The only 2 people I got was Karina Butler and Owen DeBarra, who were willing to actually say, yes, Sam, you can give my number out. So there's a lot of reluctance of people to talk. I also have a hospital appointment in Beaumont, but most people don't realize that because, again, I'm constrained in what I can say. I'm not the spokesperson for Beaumont Hospital. I want to respect the CEO's decision that I should not speak on behalf of Beaumont Hospital. So I very much try not to, but I do have an academic appointment, which obviously I use, and that's fine. So there are constraints, and quite rightly so, in any big organization, that you have to be respectful of your bosses, and there's nothing wrong with that. That's the way I think organizations have to function.
Mm. Thank you, Sam. And I think I suppose another disparity is there's the geographical one, in that most of the media is centred in Dublin, and for people that are unable to travel or can't travel, and again that might have caring responsibilities or other duties, can't just hop on the train or the bus to drive up for a 10-minute slot on the Today Show or the Tonight Show or Claire Byrne as well. So there are geographical problems and issues there as well too. Gabrielle, we'll move over to you for some thoughts and insights.
I mean, I completely agree. It's extraordinarily important to have women's voices in 2 respects, both on the professional and expert sort of roster of people that the media talk to, but also women's lived experience as well of COVID-19. We're not hearing enough about that. I just want to contrast. I hadn't really thought of it in the Irish context. I do the majority of media stuff I do, which is a huge amount, I do with London-based media, and I'm dropped all the time, I should tell you, from panels because they insist on having both a gender and an ethnic balance on panels. So I get calls all the time telling me, sorry, we can't use you today. And they actively curate their panels to make sure that they are representative. And I absolutely agree, people like me should say, no, you really need to, you shouldn't have me, you should have other people. But actually, the responsibility, the prime responsibility, lies with the media organizations. They're the people who are putting people on the radio or in front of the camera. And they're the ones who should be monitoring and making sure that they do produce balance.
Absolutely. I know in UI Galway we've had our challenges with gender in the past, and we've had gender quotas for committees now, which has been very, very important. One of the issues we've had now is trying to get a man on the committee sometimes, but that's okay. We're okay with that. I'll just move to some questions that have come in from some of our attendees as well. One attendee was just wondering about the lack of primary care in Ireland and how that has impacted the COVID response. If anybody would like to answer on that.
I'm just not sure, Nessa, what do they mean by primary care?
It was just a generic comment, I think, that came in on the chat. Maybe primary care facility.
We have very strong primary care in terms of general practice, so I don't follow that question really. You know, general practice is probably one of the most functional parts of our systems in terms of access and follow-up, so I'm not sure I follow it.
I think there was just a reference there came up in terms of the use of ivermectin. I don't know if that is. No. Okay.
I can come in on ivermectin. I mean, we're not using it yet because we don't have the evidence to support that yet. But who knows? That's one of the nice things about COVID is to see how quickly research evidence can emerge. So.
Okay.
Just to say, it was discovered by an Irishman from Donegal, so I think we should take some credit in that.
We'll add it to the list and the roll call. Another question just came in there as well in terms of the impact on trauma. Oh, sorry, Ivan, sorry.
I was just going to add to the ivermectin. I understand that the manufacturers of ivermectin are currently not recommending it for use in COVID-19.
Okay, thank you very much, Ivan, for that. A comment came in from Sharon on a question of the idea of trauma with regards to healthcare workers and their children, and there's the question of, can this be vicarious trauma, or how do you see this playing out in the future, Sharon?
Yeah, so vicarious trauma is trauma that you know, from being around people who are traumatized. So I think that we don't know enough yet about what the mental health impact is on people. It will be disproportionate on particular groups. Just like Cliona said, there are people who are disproportionately impacted by COVID. So from talking to psychologists who work in the community, something interesting has happened actually, is some families have found that their children's mental health improved actually because of lockdown. Because for some children, the demands on them of being outdoors was too much, and you know, families, but it's a small group. There's a small group of children where there's been some improvement, but then you have other groups. So you have the children of healthcare workers, I've said, and other frontline workers who are mostly female. And Frances Fitzgerald outlined some startling statistics there in relation to the amount of very important roles that have women in them. And then children who are living in domestic violence, children who are living in poverty, children who have unequal access to education. We won't know the impact of that for some time.
Okay, great. Associated with that as well was a series of questions that come in and comments as well on that. COVID has, that much of the emphasis has been on the physical health of the country, and maybe not as much has been placed emphasis on the mental health, and particular reference was made to the impact on suicides as well. And would anyone like to speak on that? Cliona,
I might come in. I know Gabrielle was putting stuff in the chat, I think, as well. So we have a really poorly resourced psychiatric mental health sector anyway. And then there are other things like the housing crisis that really, you know, we're at a very poor point in starting. So we fund our mental health services to about half the amount comparatively to other services that our other comparators in Europe should. And they have really suffered the patients in mental health services during this pandemic. I have a great friend who's a psychiatrist here in James's, and it's just heartbreaking to see how they're trying to stretch something that already was incredibly thinly stretched even further. And then, of course, you know, we're social creatures, so the lack of social interaction, people being in their homes, we've seen a lot of relapse into addiction, the stresses of trying to balance work and homeschooling or work and small children, which is impossible. You know, I think that has also been seen very dramatic in mental health. So yeah, absolutely. Now is a good time to maybe take stock of how we do things, and that would be one of the key things I think we'd be calling for.
If we could have a balance of men and women at the table when we do take stock, that would be even better.
That would be fantastic. I just have to come in to say to Sam that I have done many late night television shows and 6:30 a.m. So, and I have children, and Sam didn't text me over the summer. So sorry, Sam.
There'll be private phone numbers flying around now. After
Jesus.
Gabrielle, I think you wanted to come in there again as well.
Yeah, it's kind of actually just on that same point, you know, I turn down about 90% of the media requests I get, because as Vice President of the IHCA, I get so many, and they do still come back to me, but I do often redirect to people when I feel that someone else is a more appropriate choice for it. And sometimes if that person doesn't have as much of a profile as me, they don't want to. And so I will do things like say, well, I'll come and be on the panel, but this person will be the main speaker. But if you want my profile, then I'll support it that way, especially if I'm being asked around things around minority and advocacy things that I might have raised, where there's somebody who should be centered on it. And so I'll use my profile to platform them, because it's very important, especially around, you know, traveller rights, minority issues, the Black community, disabled people, that the people who are most affected are the people who are actually centred and who are leading the discussion, because there can be a tendency, especially around disability issues, to be ableist. The other thing I'd say is that I do see a difference in how women and men are treated within organisations when they speak up on advocacy issues. And I work in multiple hospitals, and in one of the hospitals, there's a male colleague who's very vocal, and he never gets taken to task by management. And I do, and other women in the organisation do. So there are gendered ways, even in how women are treated when we do actually speak up. And that can make other women scared to speak up. We live in a patriarchal society. You know, the rules are designed around, and that's the way it is. That's the way it has been. And so even though times are changing, the structural inequalities remain. And so women actually, and Sarah Fitzgibbon raised this in the chat, and she's the founder of the Women in Medicine in Ireland network, women need to be supported to speak up. Women tend not to want to speak until they're absolutely sure they're 100% right. I don't tend to have that problem when I'm asking one of my male colleagues to cover me. And again, some of these things are uncomfortable, but everything that I'm saying is based in literature. And these are things that we have to address if we want our society to be more fair, more equal, and more representative of everyone, where nobody is left behind. And coming back to what Kelly said earlier, you know, people with rare diseases, they definitely feel left behind today. People who are under 70, who have been cocooning because of medical vulnerability, who are so low down on our vaccine prioritization currently, they feel appropriately left behind. And so we have to hear their voices. Their voices have to be at the table if the best decisions are going to be made to be representative of them.
Yeah, no, absolutely. And I think the question of underrepresented groups, whether it is women or members of the traveling community or those that have underlying health conditions or children with siblings that are unable to attend school, again, we need to be cognizant of all of the critical blind spots and structural deficits that are there. All the more reason why we all need to be on the table and sitting around the table discussing and planning and future proofing the recovery through the response in many ways. Kelly and Shauneen, I'm conscious that you are experiencing this right now from your own very personal perspectives as well. And we like to have a balance of expertise and experience on these webinars. Kelly, would you like to say a few words?
Yeah, so I would be happy to give interviews. I just don't get asked to do interviews, mainly on the basis that we feel like in the media that we're wanting to hear from more common diseases. We want to be hearing from cystic fibrosis patients. We want to be hearing from COPD patients. We don't want to be hearing from somebody with a disease that's never been seen in Ireland before. And I'm not the only one with a rare lung disease in Ireland. I know many people with rare lung disease in Ireland, but just nobody wants to seem to hear from us.
Thank you very much. Well, I think that's something that we can all be cognizant of. And again, that need for a broad allyship, I think, across all of the different expertise, whether it's media or academia or in the public health frontline or healthcare workers, that we all share experiences, but also help put people in places where they can speak if they feel they're ready to do that at particular times. Shauneen, would you like to add any few words there with that?
Yeah, I mean, I did an interview for the BBC back, I think it was in December, the middle of December maybe. Just basically the same, just discussing my experience with cancer during COVID. I got quite a good response. But I think, I don't know about down in the south of Ireland, but up here in the north, we definitely, there's a limit of people. I've heard so much, I say grim stories, but I think at this time when people are in their homes and they're not getting out and they tend to not be looking so much at the news maybe, or just switching off. I know myself, whenever I was going through my treatment, I couldn't even watch the news. I'm a big news person. The thought of all the things that were being said on the news every night was actually very disturbing for me. I just couldn't watch it. So, but it is important that, yes, if we're asked and if we're able to get the words out to try for whatever group, and I agree with Kelly there that cancer is one of those obvious ones that they go to because, and there are people and other conditions out there that you aren't hearing about that need to be brought to the fore because, those people are at home and aren't being dealt with the way that they should be.
Thank you very much, Shauneen. I might move maybe to either Helen or Andrew. I'm conscious that a lot of the discussion has been focused on this side of the border. So are there any perspectives or thoughts from how all of these discussions are playing out in Northern Ireland at the moment as well? Helen, would you like to add any thoughts there? And then I'll move to Andrew then.
Well, I would only say that I recognize all of the discussion. I don't think there are so many differences on specific issues. Perhaps there have been differences, for example, in the way schools were left open for the children of key workers in the north, and I think less so in the south. So there might be specific differences, but in general, all the issues that the speakers have highlighted are similar in the north and in the south. And the pandemic has just exacerbated all the problems that people already had. Got worse. If they were well off, they got better off. If they were worse off, they got even worse off. And so we have now exacerbated inequalities, and it's going to take time to recover from that. But I suppose as we talk a lot about the zero COVID plan and getting down to zero COVID, which is really necessary to tackle these issues and to keep it down. But we need to start thinking as well about the recovery plan ahead, because as Frances Fitzgerald was saying, thinking ahead of how we're going to put our society back together again. Now, not just how we're going to cope with the current pandemic conditions, which are bad enough, but we have to do both together.
Yeah, thank you very much, Helen. Thank you. Andrew, are there any other further thoughts or considerations there?
Yeah, so, I mean, I can't speak of the personal circumstances that a lot of people have faced, but I mean, I've got a strong interest in the inequalities that were present before the crisis, and they've only got worse during the crisis, as Helen says. And I think there's a lot of media silence over the inequalities and a lot of problems, including with transmission things. And I think spoke last week about this, was that the occupational transmission is often ignored as a factor, and the inequalities in that creates have rarely been mentioned. And the stay-at-home message applies to some people, but it doesn't work for others who have to go into work. And the risks people face, including healthcare workers, are often underplayed. And I think the RTE show yesterday kind of at least did give an insight into that. And I think we need more of that to be seen on both sides of the border.
Absolutely. Yeah, thank you. Absolutely, Andrew. And it's something that I think we're very cognizant of as well, is taking that all-island perspective and understanding. And many people travel across the border, of course, too, for healthcare reasons as well, either for work or for to get treatment in different contexts. Just a number of messages have come in, and we'll probably wrap up in about 5 minutes. We've had an extraordinary amount of chat, which is fantastic. I'm sure it's nothing to do with all the women on the panel, but it's been fantastic getting all the discussions and the ideas and debates. And again, we'll try our best to address them here on Twitter again afterwards. But one issue we haven't actually touched on that's really important, I think, is the role of family carers. And there's an extraordinary amount of family carers in Ireland who are doing very often unpaid work and unseen work behind the front door. So if there's anybody on the panel would like to say anything on that, on the role of carers, Frances?
Yeah, Nessa, thank you. I mean, I think what the discussion is illustrating really is, you know, what COVID has done, it's brought to the fore all these inequalities. And the very big question, as I said at the beginning, is, you know, is it going to make them all worse? Or can we kind of take them into account now in the recovery going forward and really address them more fully? And, you know, there's been such a crisis around, you know, the physicality, if you like, of COVID, and the focus has been so much on, you know, the details now with the vaccination and originally and still the details of the illness, that these social issues and these inequalities haven't been getting the kind of space I think that they need to get. And ironically, they're also part of the recovery. I mean, that's the reality, because we have to work with the groups most vulnerable, you know, to protect them from COVID as well. But on the carers, I think it's a really big issue. And one of the carer groups said to me recently, you know, there's so many people doing caring, but they actually don't even almost identify as carers. They're just, you know, they're getting on with it. And I, you know, at a European level, I'm trying to get a European care strategy in place so that we really look at the working conditions, like across Europe and in Ireland. So many of the carers, you know, they can be migrant workers. They have less rights. You know, it's often the very informal economy and so on. And I just think we have, you know, we really need to get get much stronger about supporting carers. And you know, COVID, I suppose, has shown us a bit more what people value, you know, in terms of that appreciation of frontline workers and carers and so on. But you've got to turn it into reality. You've got to turn it into income for people. You've got to turn it into dealing with, for example, the gender pay gap, which is a big issue in the caring area. And you have to, you know, examine the supports that we need. So in the recovery package, we should be looking at what is needed around care. In terms of daycare centres, and you know, money could be put into that sort of area, and informal and community care supports. Of course, we've seen many of the problems in residential. So you know, there's a real need for us to talk about these things and respect the huge amount of work that is being done by carers, both in the home and obviously in hospital settings. And I think we've come around to seeing the hospital work much more, actually. And last night's program, I mean, I thought did it very, very effectively as well. And we just need to hear and see more about this. But some of the media discussion tends to focus on the kind of the technical sides of the illness, the technical vaccines and so on. It is harder to get these social issues out there, but we've had a good discussion on it this morning, I think.
Mm-hmm. And I think as well, it's been something I think that maybe has been absent or maybe not as present as much as it might, kind of, you know, the human life and the human lives behind the data and the numbers and the statistics that we hear every night. And there's a real risk of becoming desensitized to that. And you see just the numbers going up and down and the graphs going up and down, but actually looking at the impact that what each illness has on how many people in terms of the healthcare workers that have to look after that individual and the families and the communities as well. But again, those issues of value and what's valuable in society, I think COVID has really brought that to the fore, and also what kinds of lives are valuable and that we need to mind and look after. I'm conscious of time, and many people have other responsibilities to go to after this. Are there any final points that anybody would like to raise? Kelly or Shauneen in particular, or anybody else from the panel? I know that Cliona had to leave earlier as well. So
I suppose, can I just raise one thing?
Sharon.
Is that I struggle as a mother and as a woman to see how decisions are being made where there's an understanding of the day-to-day running of a home. So very practical things, and I'm very concerned about people who are in low income roles, and people in different areas in the country. Things like not being able to buy children's shoes and children's clothes, having to buy them online. You can't buy cheap children's shoes and clothes online. And you know, I mentioned this on the Claire Byrne show. People laughed because there were queues of women outside Pennies when the last lockdown lifted. And the reality is that there are people who live day to day. They don't have 38 euros to spend on a pair of shoes that might come in 4 to 6 weeks, that might need to be returned, and you might have to pay to post to send that back. So for me, as a woman and as a mother, I struggle to see how day-to-day practicalities are taken into account when decisions are being made. So, you know, I mean, the off license is open in our village, but I can't buy children's shoes and can't buy children's clothes. So if there's more representation, there's almost no representation of low income women or women from minority groups in decision making.
Yeah, absolutely. And I think it shows as well the kind of the unconscious bias, I think, that has been prevalent in a lot of the discussions as well, and the assumption that there's somebody else at home to put on the dinner, to do the homework, to do all the running. And also as well, another aspect that we haven't really had time to touch on today, but single parent families as well, and particularly healthcare workers who are single parents and the difficulties and challenges they've had to make it up as they go along themselves, because there was no proper infrastructure put in for looking after their children and educating them. So they had to create bubbles with other healthcare workers, and many of them are commuting on top of doing a 12 and a 13-hour day as well. Okay, we could have the whole day talking about this, I think, but I would like to thank everybody so much for their time, for their experiences, and for their voices as well. It's been a wonderful panel and an absolute privilege for me to chair it and to meet you all. I do hope that we get a chance and opportunity on the other side of all of this to meet in person, but until then we will be in touch with all of you via different forms of chats and groups and different platforms, and we will extend the arms of allyship across to everybody. And I'm sure when Sam goes on holidays, there'll be lots of people going on TV and radio as well too. But notwithstanding all of that, we do really appreciate all of the different voices from all the different experiences, male and female and transgender as well, that are speaking to all of these challenges from different communities across the island of Ireland and further afield. I'd like to thank all of our participants and all of our attendees today. We've had a lot of chat coming in. Thank you so much. And we will continue some of these conversations on Twitter and on our website as well. It's ISAG, COVID19.org, and also with our People's Campaign, We Can Be COVID as well. And there will be more discussions about what will be going on for the 14th of February and other kinds of activities that will be going on in the People's Campaign for Zero COVID over the coming days. So thank you very, very much. Gur míle maith agaibh go léir as Galibh agus Slán Tamalín agus Fan Slán. So thank you very much indeed.
Thank you.